request Dr. Prapti Vilada to receive a token of appreciation.
Day-1.
Session-4.
No,
This is this is session 1, 2, 3. And now this one.
I would like to request Dr. Jyoti to present token of appreciation to our chairpersons.
This will see anything. You can see it, you can download it or you can use it.
CNS. What is CNS, sir?
Now we will
What is
move on
CNS?
to the next session.
So we are going to help in science and
I would like to invite our chairpersons for the next session. Dr. Kamlesh Patel,
I'm Dr. Sunil, Public Karnataka.
Dr. Murugesh Pastapur,
I'm Dr. Danish.
please come on the stage. Topic of the next session is silent invaders, opportunistic infections in HIV, role of Bictegravir.
Good afternoon, everyone. Good afternoon, everyone. And as you can see, we are really enjoying all the topics from the morning today. Very interesting, and including the inaugural mission was very nice. Now coming to the fifth session today, we have about 5 talks and discussion in this topic. And my co-chair is coming. So first session we have is management of advanced HIV disease. I invite Dr. S.K. Guha, my friend.
ASICON welcomes Dr. S.K. Guha. Dr. S.K. Guha serves as the director of the School of Tropical Medicine in Kolkata, a leading institution in the field. Association of Physicians of India, the Indian College of Physicians, the AIDS Society of India, and the Clinical Infectious Diseases Society, demonstrating his engagement with major medical communities. Specializes in tropical medicine, focusing on diseases prevalent in tropical regions. He is an expert in HIV/AIDS, likely involved in research, treatment, or public health initiatives related to the disease. His work likely involves efforts to improve public health outcomes in India, particularly in the context of infectious diseases. We look forward to hear him talk on management of advanced HIV disease.
There has been significant increase in access to HIV testing and counseling globally in the recent years. So also access to free antiretrovirals, particularly the fixed dose combination antiretroviral tablets. So a number of people with HIV are having free access to antiretrovirals. Still, there is a concern that mortality still continues to be high. If you look at published by UN in the recent times in 2023, there are more than 6 lakh people died globally due to AIDS-related causes. Now, this decline in death, there has been significant decline over the last 2 decades, but it has plateaued to some extent and is yet to reach the target. So, keeping that, and most of the deaths are taking in patients who are having advanced HIV disease. So I'm going to talk about the definition of WHO, the burden of advanced HIV disease, and the rationale and evidences for special packages in dealing with such patients, the screenings that are recommended by WHO, and last but not the least, the issues of rapid ART initiation. So this is the number as published in as of the end of 2023. UNAIDS estimates that around 39.9 million people are living with the virus worldwide. And importantly, 630,000 people died due to AIDS-related causes in 2023 worldwide. So this is a concern that we need to try to address. Now, if you look into the trends of death in AIDS-related deaths globally between 1990 to 2023, and we have got a target at 2025. If you can recall, sometime in September 2015, there was a global call of endAIDS by 2030. That was the global call, and in keeping in with that call, there were targets were both initially to be achieved by 2020, and then it has been extended to 2025. So the calls, the numbers, the targets were reducing the new infection to less than 5 lakh per annum, reducing the death below 5 lakh per annum, and reducing the HIV-related stigma. Basically, it tried to cut short the mortality by more than 90%. So the target of 5 lakh is we are reading here in 2025. And the last data that was published in 2023, it was clearly above 5 lakhs. So WHO defines advanced HIV disease as someone who is infected with HIV and having a CD4 count of less than 200 at initial presentation, or someone having WHO stage 3 or stage 4 in adults and adolescents, and all children infected with HIV and below the age of 5 years are considered to be having advanced HIV disease because of their immunosuppression, degree of immunosuppression, and immature immune system, and also faster progression of the disease amongst children below 5. So let's look at the figures. I have taken few publications from in recent times, one from Africa, that shows that proportion of people who are starting ART with advanced HIV disease, that was about 55% throughout Africa. It varied from country to country. It was Swaziland, it was 31% to even 77%, as high as 77% in Senegal. The famous Athena cohort of Netherlands, one of the largest cohort of HIV patients in Europe, it has shown that between 1996 to 2014, 53% were actually late presenters and 35% had advanced HIV disease. In India, a study from Southwest between 2012 to 2016, amongst 40,000 odd patients, among newly diagnosed patients, there were 45% were actually having advanced HIV disease. Into our own data, the national program data, if you can recall, in 2017 we adopted a treat all policy in our country. So anyone having HIV positive are being put on antiretroviral therapy regardless of the clinical stage or CD4 count or any particular patient population. However, significant patients, number of patients, almost 1/3 of the patients who are registering with the ART centers, they are still having CD4 count of less than 200. Although the median CD4 count at ART initiation has risen considerably from 2005 to 2018-19 onwards, is almost reaching 300 now. But then again, there are late presenters with advanced HIV disease, and these patients often have multiple opportunistic infections and critically ill, and despite being admitted in hospitals, they often have a negative outcome. So the question comes, why do people hospitalized with HIV have poor outcome? As I said that This is a global analysis of the data published by UNAIDS. Around 20% in hospital mortality and 19% of patients PLHLE who got discharged successfully from the hospital, they are readmitted within a year, and 14% die after discharge from the hospital. So these are alarming issues, and as I said, there are multiple opportunistic infections seen amongst people who present with advanced immunosuppression, maybe TB, cryptococcal meningitis, maybe TB, pneumocystis pneumonia, etc. And the commonest cause of death globally is tuberculosis, cryptococcal meningitis, and severe bacterial infection, which often are not diagnosed in certain level of healthcare settings. And not only that, sometimes patients are successfully treated for the event that for that patient is admitted, maybe an opportunistic infection, gets diagnosed, treated, stabilized, and discharged, but the patient doesn't get linked with the care program, which is essential. And some of the conditions following discharge, they would require further care because long-term disabilities are also quite common in certain number of patients. So I take the help of two studies, the RAINSTAR study and the reality study. These are basically shown how intervention or package of intervention in terms of screening, diagnosis and treatment can improve the outcome of some advanced HIV disease. First, the RAINSTAR trial, it was carried out as an open randomized control trial carried out in Tanzania and Zambia. About 2,000 ARV-9 patients with CD4 count less than 200. They were randomized to receive the standard of care of the country national guideline, or they had some intervention through enhanced screening-based care. All study subjects, that is nearly 2,000 study subjects, were actually screened for tuberculosis by expert MTB-RIF. The enhanced screening-based care, the patients, in addition, they underwent serum tract screening, and preemptive therapy with fluconazole was given to tract-positive patients. And the other intervention was in the enhanced screening-based arm was weekly home or community visit for first 4 weeks of following ERT initiation by trained lay providers in African setting. And what are the outcome? At 12 months, the mortality has reduced considerably by the tune of 28% in the enhanced screening-based care over the standard care arm. So it showed that screening for cryptococcal antigen in those two countries with preemptive treatment for tract-positive patients did well. So also support, initial counseling support through home visits also helped in reducing the mortality. The reality trial, on the other hand, it was carried out in 4 countries, Uganda, Zimbabwe, Malawi and Kenya. Nearly 1,800 ARV-9 advanced immunosuppression with CD4 less than 100. They were randomized to receive either enhanced antimicrobial prophylaxis or standard prophylaxis. And enhanced microprophylaxis constituted of single dose of albendazole, azithromycin for 5 days, fluconazole low dose 100 mg for 12 weeks, and one fixed-dose co-formulated tablet that has double-strength cotramazole base with IMH and pyridoxine for 12 weeks. And the standard prophylaxis was a double-strength cotramazole. The trial results have shown that at 12 to 24 weeks, the mortality was reduced by, overall mortality was reduced by 27%. Cryptococcal prevalence was reduced by 62%, so also the cryptococcal mortality was also reduced. TB incidence was reduced because of IPT. Hospitalization rates was reduced, but there was a concern about whether the pill burden will compromise the adherence or not. There was additional pill burden, didn't reduce the adherence significantly. There was no difference in serious adverse events. and cost analysis has shown that it's a cost-effective strategy. Based on these two studies, developed certain disease-specific tests for screening and diagnosis of opportunistic infection in advanced HIV disease. Serum cryptococcal antigen test, it has a sensitivity about 100% and specificity of 99.5%. It used to be done earlier on with latex aggregation test, now lateral flow assay, which is easily available point of care test is available, that is being practiced. And it is recommended that it should be offered as a screening test for adults and adolescents with CD4 less than 100, and it may be considered for those with CD4 less than 200, because the prevalence is more with CD4 less than 100 as compared to between 100 to 200. And those with signs and symptoms of meningitis, cryptococcal meningitis should also be tested for that. It recommends that serum, if the antigen is positive, then one should go, the patient should be carefully evaluated and examined, and for presence of meningitis, and lumbar puncture should be done, and the CSF study has to be done, including CSF cryptococcal antigen. Regarding TB screening procedures, as we all know, it is recommended for all HIV positive subjects, whether adults or children, on each clinic visit should be evaluated for presence of tuberculosis. And the commonest screening is done through 4 symptom screenings for both adults as well as children. And it can also be aided by chest X-ray without computer-aided detection. Nowadays, these are also available for digital X-ray. And CRP, there is a notion to bring raised CRP, whether that also improves screening or not. And sputum molecular test in certain settings where available, depending on the prevalence and the availability, one can go for the sputum molecular test like GenExpert for screening. And all skin positive subjects must have a diagnostic test for tuberculosis. And those who are skin negative, they should receive TB preventive therapy, either IPT or 3HP. Now 3HP is also available in the country, so with the ribofentin and INH high dose, once weekly for 12 consecutive weeks is also mentioned. Urine lateral flow lab is a popular test, and once again it has been recommended for adults, adolescents and children with signs and symptoms of tuberculosis, whether pulmonary and or extrapulmonary TB. Those who are seriously ill and into WHO stage 3 and stage 4 condition, and even in asymptomatic adults with low CD4 count, in inpatient setting less than 200 and outpatient setting less than 100, they should also be offered lateral flow lamp test. Sensitivity is low, 56%, but the specificity is high, 90%, particularly in CD4 less than 100. So very sick person, the patients, those CD4 count, their lateral flow lamp, and the test takes about 25 minutes time to get back the result. However, we need to remember that a negative lamp does not rule out TB. If it is positive, you can initiate TB treatment, but further TB testing, particularly the testing with GenExpert should also be done, and also the culture, as we have discussed earlier on, because the lab cannot identify drug resistance. So knowing the resistance pattern would be important, but it can save time by initiating TB treatment early. And the molecular test, once again, the moderate sensitivity of pooled moderate sensitivity is 69%. Specificity is very high among all PL-HIV, around 98%. Use when someone is screening positive or diagnosed as presumptive TB, they should be offered, they should be subjected to this the molecular test. And molecular test, we have got GenExpert, GenExpert Ultra, the TrueNut Plus test, and the NACO. These are the 5 recommended by WHO. Adults and adolescents, we take sputum or other respiratory samples, and in children, in addition to sputum, Nasopharyngeal aspirate, gastric aspirate and stool is also recommended to be examined. And for presumptive extrapulmonary TB disease, large urine CSF, lymph node aspirate or lymph node, biopsy, pericardial, synovial fluids are indicated as indicated by symptom as well as the likely site of anatomic site of involvement of three organs. You need to remember that non-symptom samples and pediatric particular they may vary in microbacterial load and may be false negative. So maybe need to repeat it or need to go for the now the CSF, as I said earlier on, should be used for a screening test for adults, adolescents and children with signs symptoms of cryptococcal meningitis, the positive serum cryptococcal antigen. If lumbar puncture is without it, we should go for it. Histoplasma antigen test, where histoplasma is endemic, particularly in certain areas of Americas, the northern part, the central as well as the southern part, and southern African and Asian countries, including our own India. We have in the Gangetic Delta, we get to see cases of histoplasmosis at times. So we need to keep that in mind. So histoplasma antigen test should also be done. Malaria, definitely we do it in malaria endemic areas as well. Now that brings to the last issue, the rapid DRT initiation. Now our psyche was when we were trained in the last 3 decades back in HIV medicine that the patient should be, OI has to be diagnosed and treated and stabilized, and then ART has to be started. Because there is no hurry in starting ART, but then again, evidences have suggested that probably rapid ART initiation, not only it controls the viral load early, prevents transmission, but it also helps in retention of care and also reduces mortality. So keeping that in mind, now the WHO advocates that ART initiation should be offered to on the same day to people who are ready to start. By definition, rapid ART initiation means starting antiretroviral therapy within 7 days of a confirmed HIV diagnosis. If it is not feasible, one can aim at between 3 days, or even some patients might agree to start antiretroviral therapy. Asymptomatic, absolutely asymptomatic individual can also with a high CD4 count can go for same day start of antiretroviral therapy. There will be challenges, system challenges like getting back the reports on time, the workload, etc. So maybe 3 days or 7 days can be a good alternative. Only thing, there are 2 contraindications where we should defer ART is presence of meningitis, particularly TB meningitis, when one has to wait for 4 weeks, and if it is in cryptococcal meningitis, one has to wait for 4 to 6 weeks. So to summarize, despite the rapid scale-up of antiretroviral globally, significant proportion of patients present with advanced HIV disease, and amongst these subjects, the mortality of HIV is very high, and the package of, as I discussed about the WHO package of improved screening and diagnostic tests for OI, enhanced prophylaxis and preemptive treatment like fluconazole for crack-positive individuals, rapid ART initiation and augmented adherence support is essential to reduce mortality. And in our country, we are facing challenges with availability of crack widespread in the national program. So also the urinary lateral flow lab. Of course, there are some multicentric studies are currently underway with urinary left lab regarding this efficacy, effectiveness, and feasibility study. So thank you. Thanks for the attention.
Thank you, sir. Thank you for the lovely talk about management of advanced HIV diseases. I think any questions we can ask in the last discussion time? Thank you, sir. Now we call upon the next speaker for another lovely talk. Dr. Sanket Mankar is an IT specialist from Ahmedabad. He will talk on PCP, the past and present. Dr. Sanket Mankar.
ASICON welcomes Dr. Sanket Mankar. Dr. Sanket Mankar is an infectious diseases and HIV consultant, CMC fellow. Dr. Mankar's expertise covers a wide range of infectious disease challenges, including HIV medicine, transplant infections, severe sepsis. He aims to manage a hospital infection control company, demonstrating a commitment to preventing nosocomial infections. Dr. Mankar seeks to handle complex infectious disease cases, showcasing his advanced training and skills. We look forward in hearing him talk on PCP past and present.
Very good evening. Thank you very much, ASICON, for giving me this opportunity to come here and present my views on pneumocystis aerovecchi pneumonia, past and present. A special thanks and warm welcome to my eminence professor, Dr. Dilip Mathai, who trained me in 2010 to become an exclusive ID consultant. Thank you very much to IDSC also for giving me this opportunity to come here and present my views on PJB, past and present. So if you look at PJB, was first identified by Shah in 1909, mainly as a trypanosomal life form. And Kerenii was somewhere down the line much more interested in these things and had similar findings and thinking. Delanoy in 1912 classified that as a separate species from Trypanosoma. As years went by, Erovic grew more interested in this particular organism, and he established that primarily the interstitial lung disease that was developing in these premature infants was caused by this particular organism. In 1981, by and large, a group of MSMs started developing this particular pneumonia, which was identified as PCP eventually. Right. So, if you technically speaking, it was initially classified as a protozoa, by and large because of its response to various anti-protozoal drugs, but now classified as a fungus because of its genetic analysis of ribosomal RNA. In addition to that, as you all know that one thing, beta-glucan, one of the fungi, has also been verified. So, if you look in a nutshell, pneumocystis is an opportunistic infection that still is prevalent in HIV/AIDS and in non-HIV population also. Among those with HIV who are at greater risk are those with CD4 counts less than 200 cells. And if you look at the burden of serious fungal infections in India as of now, at all has described the ambient incidence rates of PJB, invasive aspergillosis, mucor, esophageal candidiasis, fungal keratitis and cryptococcal meningitis, which is far more commoner than the endemic mycosis that we do observe. By and large, pneumocystis pneumonia tends to occur at the rate of some 4.1 odd at 1 lakh population. So if you look at the past, the way PCP and PJB had progressed, by and large, it follows the life cycle in the form of trophic forms and cystic forms. The trophic forms tend to attach to the type 1 alveolar cells and produce overwhelming inflammation, which mainly accounts for the excessive mortality that occurs in PJB cases. So if you look at the microbiology and pathogenesis, the key components being lymphocytes, macrophages, which principally mediate the uptake and degradation of the organisms in the lungs. Cytokines and chemokines again being responsible for the overwhelming inflammation that occurs in a case of PCP pneumonia. So exuberant inflammation promotes pulmonary injury in a case of PCP pneumonitis. If you look at the epidemiology of transmission, initially the route was pretty uncertain, and later on it became more evident that airborne transmission was the main route of transmission, mainly because of the geographical clustering of the cases that was happening. Airborne transmission was detected in animal models, detected air samples from patients. In addition to that, vertical transmission also was proposed due to colonization does occur in patients with HIV, chronic disease, mainly COPD, diabetics, patients with underlying malignancies, and many patients with corticosteroid treatment, particularly patients who are on doses of more than 20 mg of oral prednisolone. Right? The clinical significance of which translates into non-HIV related increased incidence of PCV pneumonia. The groups at risk for PCV include HIV mentioned, and as we all know, less than 200 CD4 cell count. Non-HIV immunocompromised host, where routine use of PCV prophylaxis is not there, is an emerging population where you find increased PCV prevalence. So hematological malignancies, particularly ALL, patients with corticosteroid use, patients who are on fludarabine, vincristine, cyclophosphamide, rituximab, and anti-CD52. This all entire population now accounts for the increased incidence and prevalence of PJB pneumonia. Solid tumor definitely, because steroid use seems to be a common predisposition in those cases as well, right? Followed by collagen vascular diseases, particularly vaginous granulomatosis, where you are tapering of steroids, SLE, and several other collagen vascular disease. So this is what routine ID specialists would see in non-HIV settings of the patients. Patients with SOTs, that is lung and heart transplants, you would be finding PJB pneumonias, particularly for 6 months of post-transplant period. Particularly, patients are missing that trim sulfur. Bone marrow and HSCT patients where severe immunosuppression makes them vulnerable to PCP. So if you look at in HIV positive individuals, subtle onset progressive dyspnea with a low grade fever and a non-productive cough, which produces on to acute dyspnea with chronic chest pneumothorax develops. So what in HIV negative ones? So abrupt onset of respiratory insufficiency is the hallmark in non-HIV population, right? And it straight away correlates with increased dosages of immunosuppressant medications, right? And mortality remains pretty high in non-HIV populations as compared to that of the HIV populations when you are covering carcinoma, transplantation, and connective tissue disease. Right. So typically the features of a bilateral classical interstitial infiltrates, which with a normal chest X-ray at baseline, where HRCT is much more sensitive, and your HRCT showing classical ground glassing opacities, predominantly in perihilar regions of the lungs with thickened septal lines. Atypical.
To tell you, they are trying to figure out what causes a chronic diarrhea, and then managing it is one of the most challenging things for a gastroenterologist. So it's a hassle for me to sit here and pretend I can talk about chronic diarrhea and HIV, right? So with that caveat, let's think about it. So, you know, it's a significant cause of severe morbidity and occasional mortality. Debilitating illness, common cause of severe malnutrition, and the management involves both the immediate supportive treatment, the diagnostic evaluation, and in the supportive management, you not only have to worry about hydration, but also nutrition, micronutrients, and then also manage acid-base disorders. Just to illustrate, about 10 odd years ago, I saw a 14-year-old girl who weighed approximately 20 kilograms. She was lying in a fetal position in bed with severe chronic diarrhea, hypoxic. She was basically skin and bones. And all people, my colleagues that I was trying to get them to help me, said, look, she's too sick for us to do anything. So what do? Well, I start her on everything. Pneumocystis treatment, CMV treatment, nutritional support, steroids, and hydration. And amazingly, she did get better. And a few months ago, she came to my clinic walking. She was taller than her mother. And I asked her, what are you going to do? And she says, I'm going to grow up and work for the government so I can help people. So, that picture is from a science article, a news article about HIV in India from about 20 odd years ago. And it's sort of emblematic of what you will see in people with bad HIV infection and advanced immunodeficiency. You see, she has essentially marasmus. And this is what we not uncommonly see. So, part of my comments are based on what's present in the literature, but a little bit more has been added on because of my experience in India, dealing with very tough cases with practically no access to any kind of diagnostic evaluation because of cost constraints. So what do you do? So that's some common causes. Okay, isosporiasis, very easily treated with trimethoprim sulfa, cyclospora, again trimethoprim sulfa. Cryptosporidium, nitazoxanide, there's some data to suggest clofazimine and statins might work. Microsporidium, which is now thought to be a fungus, not a coccidian anymore, albendazole, fumagillin, and for keratitis, actually voriconazole is amazing. Entamoeba histolytica, metronidazole, paromycin, and then the luminally active agents for terminal treatment, iroquinol and naloxone furoate. Giardiasis can be pretty troublesome. We've seen in non-HIV patients recalcitrant giardiasis resistant to metronidazole and tinidazole and requiring multiple courses of treatment. So it can be pretty problematic. So more common cases in India, always in tuberculosis. I can't tell you how often I've seen tuberculous enteritis and also tuberculous peritonitis in people with bad HIV infection and a relatively well-preserved CD4 presenting as a chronic diarrhea. So this is something that's very important. Histoplasmosis can affect anything in the entire GI tract, starting from the mouth all the way down to the other end. Mycobacterium avium complex, this was the bane of our existence before heart and advanced HIV disease. We saw it in everybody. We saw a lot of bacteremias with Mycobacterium avium complex. We saw a lot of really recalcitrant diarrhea. CMV, this is a toughie. Now, CMV in the gut is slightly different from CMV anywhere else. For one thing, blood levels of CMV don't necessarily correlate with CMV disease in the gut. So we've seen people with necrotic esophagus, pretty bad colitis, whose blood PCR was negative for CMV. The viral load was negative. When repeated a week or 2 weeks later, it became positive. And also, the fall in the viral load of CMV does not necessarily predict what will happen in the gut. So the only utility, I think, in CMV viral loads in the blood in CMV disease of the gut is if it is positive at a high load and you're using an antiviral agent and demonstrate an appropriate fall in the viral load in a couple of weeks, maybe that helps you improve your ability to prognosticate about what might eventually happen with CMV disease in the gut. The other part of CMV disease in the gut that's very important to know is that it may take a very long time to improve and clinically resolve. And very often, along with CMV disease of the gut, you have severe gut dysfunction, malnutrition, dehydration that all need to be addressed. Sometimes the CMV's immunosuppressive effect also puts you at risk for other opportunistic infections, in particular pneumocystis. We have seen occasional cases of adenovirus colitis. We've seen occasional cases of persistent norovirus, persistent C. difficile, occasionally persistent shigellosis or salmonellosis that we associate more commonly with acute illness and not a chronic diarrhea. And also some helminths, roundworms, hookworms, wigworms, strongyloides, including a hyperinfection syndrome, schistosomes like Mansonia, and also trichomoniasis. Some uncommon causes: drugs, protease inhibitors, and NRTIs. Very rarely exocrine insufficiency of the pancreas, although exocrine insufficiency of the pancreas presenting as a diarrhea is rather uncommon. They just present with weight loss. So if you get a very low elastase in the stool, maybe that helps you make that diagnosis. We've seen lymphomas of the gut, mostly non-Hodgkin's. We've seen Crohn's disease, we've seen ulcerative colitis. See a fair amount of gluten enteropathy. For some reason, there seems to be a lot more gluten enteropathy in India than in the United States. I mean, I've not seen much gluten enteropathy in the United States. I don't know why we see it more commonly in India. Lactose intolerance. Practically any small bowel inflammation or infection will give you a deficiency of saccharides. So they get a lactose intolerance, which perpetuates the diarrhea, and you're scratching your head wondering why the diarrhea is not resolving after you've gotten rid of the putative pathogen. Food allergens. This is a very, very, very tough area, both HIV as well as non-HIV, because essentially you will spend months with a diet of exclusion to try and figure out which food allergy is causing the chronic diarrhea. And it can be really, really bad. Patients can become extremely sick, lose a lot of weight. So be careful about that. And finally, this is something that we used to think about in the old days, which is pretty hard, which is AIDS and neuropathy. And basically what this was a complete absence of any lymphoid tissue in the gut and a chronic diarrhea for which we could not find any other causative etiology. And therefore we just called it as a diagnosis of exclusion, AIDS and neuropathy. And on biopsy, we really didn't see anything other than simply loss of villi and general atrophy of the lymphoid tissue of the gut. So here's a picture of histoplasma. Remember, this is a small cyst with a narrow base budding. So if you get lucky and you demonstrate it in tissue, which is kind of unusual, you may make a diagnosis. We have shown it on biopsy in the gut, okay? But probably a much more useful test is to look for the histoplasmic antigen. This is CMV colitis. If you get lucky again, you will see this large cell with a cytopathic effect and an outside inclusion body in the nucleus. But probably what is far more sensitive is using immunoperoxidase to stain for the early antigen of CMV. There's a bigger picture of the inclusion body and the cell in the nucleus. This is a picture of Mycobacterium tuberculosis, and you can see those acid-fast bacilli out there. And difficult always to see it. I think particularly in children, it is easier to make the diagnosis by using MAT. So you can use any gastric aspirate or stool for that matter, and MAT will help you make that diagnosis faster. Mycobacterium complex is never a diagnostic challenge. You will see the stool simply loaded with this acid-fast bacilli. So it should not be difficult to make that diagnosis. Cryptosporidium, again, it takes an experienced pathologist to see this and not miss it. So if a pathologist is experienced, they should not miss this condition on the biopsy. Another cryptosporidium. This is entamoeba histolytica. Easier to diagnose with the nucleic acid testing nowadays. We have it on the biofile panel, so you pick up entamoeba histolytica much faster than that, both in the stool as well as in abscesses of the liver or the spleen. It's easier to detect that way. Amoeba introzoid. Giardiasis, again, much easier to diagnose with Giardia than the antigen in the stool. It's a much bigger picture. And finally, one word about bad chronic diarrhea in children. This is something that's really, really very problematic because children are particularly susceptible to severe nutritional deficiencies, including vitamins. So you'll see vitamin A deficiency, you'll see the iron manifestations, you'll see vitamin D deficiency, bone manifestations, you'll see vitamin C deficiency and parafollicular hemorrhages in the skin, and so on and so forth. So I think that if you see a chronic diarrhea in a child, you should be thinking about making sure that they are getting all the nutritional supplement, fluids, electrolytes, correcting their metabolic acidosis, giving them zinc. I often give people vitamin D as well because it seems to work on the VDR in the gut and reduce inflammation. So nutritional support becomes an extremely important part of management of chronic diarrhea, both in adults, but particularly in children. So that's all I had to say about chronic diarrhea, and believe me, if you ever want an intellectual challenge, this is it. Thank you.
Yeah, thank you very much, sir. Wonderful discussion. Talk
This problem
has to be listening to you. So we have many questions. We'll take up one question. Afterwards, we can have a discussion and we are separate. You can continue.
As clinicians, when we approach this problem, we look at it as whether it is a large bowel diarrhea or a small bowel diarrhea. Now, large bowel diarrheas are predominantly, watery type, and maybe if they've got inflammatory, whether it's CMV, colitis, and things like that. But small bowel diarrhea, crampies, semi-solid stools, and other things. Now, because as clinicians, we don't have the great technology. There are instruments that can help you identify some of these organisms, etc. So we tend to do the gunshot therapy. And our gunshot therapy focuses on use of albendazole, use of cotrimoxazole, and also metronidazole. Now, cotrimoxazole is for the cryptosporidium, albendazole is for the giardia, because 75 to 80% of the organisms would get, would improve with this therapy. Only after that we begin to evaluate, because evaluation of a chronic diarrhea as a symptom is otherwise very expensive and time consuming. But when you are in academics, we tend to do the biopsy, small bowel biopsy, enteroscopies, and large bowel biopsies, etc. But it's we don't see it so much now, but still it is a problem, like you say, it's a problem.
So in chronic diarrhea, in my clinical experience, what I found is just by history and looking at the stool volume, it's not always possible to figure out whether they have small bowel or large bowel diarrhea, unfortunately.
But status, just as status.
Yeah. But one thing that might help you is if they are producing a lot of stool and they get a metabolic acidosis, then you should consider very strongly rather severe small bowel disease. Because in a pure colonic disease, you are unlikely to get metabolic acidosis. These are all normal metabolic acidosis, unlike cholera, where you're going to get lactic acidosis. But we've not seen cholera present as a chronic diarrhea that defies diagnostic evaluation. Most of the cholera that I've seen in India all been acute.
Thank you, sir. We have a separate time for discussion at the end of the session. Can we take up the questions? You have one question. Okay.
So any special pathogen for this limb disease, the so-called in Africa many years ago? Do you have any idea?
I didn't get the question. So in Africa?
In Africa, we had this limb disease.
Limb disease, yes. So limb disease, as you know, was all HIV and HIV wasting syndrome with advanced immunodeficiency. The reason why we called it slim disease is in the West, in Europe and the United States, it was easier to ignore what the hell was happening to poor Africans.
Thank you. We move to the next session. I invite our Dr. Ishwar Tirada, President of ASICON, for
ASICON welcomes Dr. Ishwar Gilada. Dr. Ishwar Gilada is a CMD, HIV consultant at Unison Medicare and Research Center, Mumbai, Honorary Secretary of the People's Health Organization India, and President Emeritus of the AIDS Society of India. Dr. Gilada's expertise is recognized internationally, as demonstrated by his role as a governing council member of the International AIDS Society. His areas of expertise encompass the management of HIV/AIDS and STDs, reflecting his comprehensive approach to sexual health. Dr. Gilada has contributed extensively to the medical literature with 250 publications, including papers, journal articles, and book chapters. We look forward in hearing him talk on dermal manifestations in HIV.
Good afternoon. So this talk will be totally in English. No Gujarati, no Hindi. Okay. I'm going to speak on dermal manifestations. And as all of you know or by now notice, skin is a protective layer, an ornamental layer, and identity layer, by which we often identify black, whitish, white, also races. And that is a special affinity for Langerhans cells. And Langerhans cells, like they have special affinity for CD4, like CD4, chromatin cells and alveolar spaces and glial cells. HIV virus has a special affinity for Langerhans cells. And Langerhans cells are there in entire skin layers. Some skin lesions are pathognomonic, some are presenting features or proxy markers of HIV disease. Some lesions are secondary to immune deficiency and due to opportunistic infections. Dermal manifestation can be due to adverse effects of ARVs also. And dermal manifestation can be part of process of aging. So somebody was just asking African skin disease. Before the era of ART, before the era of any HIV management, it used to be called HIV is the 4-stage disease: slim, trim, grim, and death. And I think millions of people would have died, and they have died during that period. About 30 years before, 35 years before, when we used to make rounds from Africa, I had also seen 7 children came from one cot, or oxygen cylinder being shared by 7 patients. And when they were collecting dead bodies, they used to do a mass funeral on every Sunday, because everybody couldn't afford funeral. And in Africa, if you have known, I think Leila is there, funeral is as expensive as marriage. So they used to share the cost of last rites or cremations. Then, first thing we have seen in HIV was varicella zoster. So as soon as we see varicella zoster, we used to ask question, when did you get it? And we used to minus 1.5 over 2 years, 3 years. That patient has got HIV 2 years before that, 5 years before that. So it was a recent manifestation of HIV disease as a clinical stage. Then during the varicella zoster, they used to get varied multi-dermatoma sometime. And particularly if it is coming on the face, our major job was to save eye. And you must have seen that some people have lost their eyes. They have got a cataract because of varicella zoster. And this lady also got varicella zoster and cataract. And lot of scars. And this boy has a permanent marker. Means if you see somebody without clothes, you can make out that this person is HIV positive. So it became a pathognomonic of HIV. In skin OPD, we used to see if 20 to 40 age group, we see herpes zoster, 85% chance that is HIV. And multi-dermatoma, almost 100% was HIV. Then we got chickenpox scars, and the chickenpox scars were like a smallpox scars, the mini smallpox, but they were for permanent for life. Then we got TB. In TB, we got, when we talk about dermal, we also talk about dermal, hair, nail, and mucocutaneous gland cells, and lymph nodes. Because we see in skin. And this fellow got TB lymphadenopathy, which was going on for 5 years. And that time, almost 20-30 years before this MDR testing, etc., nothing available. Even FNAC was hardly. So FNAC used to diagnose, treat, patient used to respond after again 1 and a half years come back. Then we got this rare case of TB where she got a swelling of her middle finger and functioning mass on the left side. So both the hands were involved. And she could not afford even skin biopsy. So we said, now this looks like tuberculosis. In HIV, tuberculosis is very common. We started treatment and within 5 months she recovered. Then we got scrofuloderma, which is very simple scrofuloderma. It can be LGB. And this, in this case, because of its ward, it was more in the favor of LGB. But on the other side, we got scrofuloderma, expert to be detected, but we were sensitive. Then we started seeing more and more fungal infections and other conditions. So what we see, most common thing was oral candidiasis, and that was a marker that whenever you, if you are following patient for many years, and the first time you see oral candidiasis is a mark that patient has got below 200 CD4 count. During those days, even a lot of people could not afford CD4 count, and CD4 counts were quite different, like ELISA or some Beats method, that method were there. And Candida balanoposthitis. This is extensive dermatophytic infection. So likewise, we used to say that to reduce stigma and discrimination, shake hand with the patient. But if you shake hand with this patient, you will contract fungal infection. And in this case, you can see that both nails, both side nails are involved. And this is auto-inoculation. Nails are involved. Scratching, wherever scratching is getting infected with dermatophytic infection. Then nail getting superficial onychomycosis and also nail bed getting infected. Now this lady got Addisonian pigmentation in seborrhea. So in the pre-ART era, a lot of patients used to come and they used to say, sir, I was never dark like this. I became dark in the last 2 years, 3 years. And that was a sign, pathognomonic sign of HIV infection. Then we started getting diffuse alopecia. And we couldn't make out what is that. But again, because of Langerhans cells were involved, because CD4 were invaded, because of immunity deficiency, got diffuse alopecia, giant keloids. Then we got Kaposi sarcoma in the pre-ART era, and when the first cases were diagnosed in San Francisco and Los Angeles, the 6 previous cases were all white, all had Kaposi sarcoma, all had basic pneumonia. So it was pathognomonic for HIV. But in Africa, there was an endemic Kaposi also. So endemic Kaposi was different. But whenever you are seeing Kaposi sarcoma outside Africa, it was 100% HIV. And we see these kind of patients. They are very hard to do, or plaques. And when you touch, you could make out that it is nothing but Kaposi. Kaposi sarcoma, HHV8, and on the dorsum and plantar of the patient, foot of the patient. Then we started seeing cancers. So, just now I spotted a any pharma colleague of mine, and I seen it looks like a nevus and it should be removed. The same thing, this fellow had a nevus of the cancers, and I used to tell him that it becomes malignant melanoma. Didn't listen. Finally, it became. We could save the patient, but he got cancer, and again post cancer we have seen 5 years. Then this is a suspected case of lymphoma, and lymphoma sometimes mimics with TB lymphadenopathy. So it's very difficult to make out if there is a lymphoma or TB lymphadenopathy. We have seen similar cases of purely TB, no lymphoma. Even from cancer hospital they were managed as lymphoma. But when they came to us, we found blood stain for tuberculosis and patient became alright. But this patient definitely was lymphoma and was finally died of NHL. Then we also, in being skin, STD and leprosy, we used to have that in dermatology, there is an inspection act. You just see and you can suspect or diagnose. So in Hansen also we started seeing cases, and we realized that what we expected. Initially we thought, because all leprosy also is an immunological disorder. So it can decide whether it is a lymphomatic leprosy or possibly based on immunology. But here we did not find any much of differentiation whether HIV or non-HIV. There was no difference in presentation of leprosy. So we could see such cases where we had nodular leprosy or leprosy, ENL, and also lepra type 2 reaction. Then we started seeing adverse reaction to ARVs. We see Steven Johnson syndrome, sometimes T and toxic epidermal necrolysis, and patient was like burn. Your whole body was with T involved, and when doctors did not realize the patient got nevirapine-related rash, they gave second nevirapine, third nevirapine, and it became worse. So whenever such cases you see, never challenge, never challenge. Then we started seeing agent-related nail hyperpigmentation. And we have seen some patients with 2 gram or 3 gram hemoglobin, and as soon as you stop AZT, given a couple of bolus pack cell volume, and they improved and they survived. Then we started, that time endAIDS was very good drug, particularly for CNS tuberculosis, and we revert that medicine. And when endAIDS was removed from market, a lot of our patients would have died or they were worse because there were no drugs available which can go and treat PML and CNS HIV. In this case, endAIDS reduced paranoia over there, and we could not make out anything. But as soon as we removed endAIDS, he improved. Then we started getting efavirenz-related gynecomastia. Gynecomastia, I got n number of cases. But during those days, there were no options available. And switching from efavirenz to nevirapine, we have seen nevirapine rash, so we never encourage that. And in such cases, whenever we removed efavirenz, patients improved. And some patients never improved, they have gone for gynecomastia. Then liposuction, etc. Then we have seen lipoatrophy and lipodystrophy both. So as soon as you see face, you can make out that this patient is suffering from HIV for 10 years, 20 years. Or you can see buffalo arm, you can see a thick arm and very thin forearm. Then we started seeing syphilis. And syphilis here was a very much unusual case of alopecia universalis. Patient has been coming for months and months, and suddenly he comes with no hair, no eyebrows, no eyelashes, nothing. And because of the history of the patient, we knew that we must check it again, the markers for syphilis, highly positive. And we treated with penicillin, patient improved, got hairs, but suddenly got recovery from alopecia, but it got pemphigoid as iris. Iris has been described only in HIV, but iris existed in many other diseases. We have seen in leprosy, we have seen in tuberculosis, we have seen in leprosy, and we have seen in the pemphigoid. So iris was already there, but a lot of terminologies were there, they came because of HIV. Secondary syphilis, again highly contagious. You shake hand of the patient, almost 70-80% chance that you become syphilis. Or you just see this kind of patient, it will be also transmitted through clothes. So syphilis, if you compare vaguely, it is 50 to 100 times more transmissible than HIV, pure by touch. Then tertiary syphilis, and it is also called gamma, and this is cellulitis because of syphilis. Then we see noroviruses. When I was thinking loudly, we realized that a lot of STDs, even HIV, has a predilection for southern hemisphere. So whether countries which look like tapered egg like India, Africa, Southern America, I don't know why. Similarly, noroviruses in India you see only in coastal belt. You don't see in mainland India. So whether you go to Chennai or Mumbai or Konkan or in the entire Bangalore belt, you will see noroviruses. And in northern part of the country, you do not see noroviruses. So noroviruses is pre-treatment and post-treatment, and it heals fantastically. You can see in this patient we have taken weekly pictures, and it healed with azithromycin for just 2 weeks treatment. HSV, again HSV is very important, and in HIV and HSV, unless and until you start ART, HSV doesn't improve, whatever treatment you do. So this is HSV labialis, and this is HSV labialis going into just like Candida moris. And in this case, it was again 2007. A lot of people put up good ART, and this was not going away with anti-herpetic treatment with valacyclovir. So we asked him to apply malai or ghee, and after 5-6 days application, he removed whole slump came out and he improved beautifully. Then extensive simplex infection or HSV genitalis improved with ART with HSV treatment. Paranasal HSV. Genital HSV, HSV going into herpes digitans, which is a CA condition, carcinogenic condition. HPV suddenly has become very important. Last 10-15 years, HPV is increasing. There are a couple of studies from Tata Hospital, Tata Cancer Hospital. Oropharyngeal HPV, almost more than 50% are because of HPV, oropharyngeal cancer. So HPV, you can see simple multiple warts anywhere in the body, but particularly on hand, if they have pets, dog, cats, etc., or they play with children. Then this patient was very difficult. It was what? It was all the names were involved, and he was a drummer in what do you call DJ. He was a DJ. So he said, I cannot beat drums, so or my keyboard. And all the names were involved because of HSV. Then some of them they get perianal carcinoma, CA penis. We have seen HPV. What's in immunocompromised patient? Sometimes it also may be neglect of ours, like a female patient, they feel shy, they don't show, and then husband comes and sees a lot of bleeding, lot of things, and when we say it's already good. So I think patient shyness also takes them to this kind of extreme situation. Other STIs, I have problems. Other STIs, we can see LGB, which is the blue sign, that the glucose is divided into two. It's a very beautiful example in STI that whenever you see a blue sign, it is LGB. And sometimes patients are, I think this patient also, there are a lot of multiple STIs. He had LGB, he had gonorrhea. You can see one small ulcer at the penis, it was syphilis. So we call such patient as a museum of STIs. TB gamma, as I said, TB gamma can present also TB or differential diagnosis can be syphilis. And Square sepsis as LGB. And then Bartholomew sepsis, which is a gonococcal infection. Again, last 20 years we used to hardly see any gonorrhea chlamydia. Now at least once a week we see one case of gonorrhea, one case of chlamydia. So at least 2 cases per week we have seen. And they respond very well, but somebody has to do investigations and treat them and create a solution. And there is also a ping-pong infection that ping is infecting pong. Pong comes to you, you treat. Again, getting reinfected from ping, but ping has not come to you treatment. So we need to have that eye to treat both. Gonorrhea, diagnosis post-treatment, we have treated gonorrhea, then we see HSV. So as I said, museum of infections. Then we had chancroid. Again, chancroid was vanished almost 20 years, we have hardly seen. Then we started seeing chancroid, and after treatment you can see the all dirty granulation tissue has changed into healthy granulation tissue. And pox. One of my first patients and one of India's first patients. It was a patient who had one lesion on mouth, one lesion on hand, and he was on shift duty. He was on prep, and from shift he used to send me pictures here. What is this? I thought mosquito bite, apply something. What is this? Then he started sending other pictures. So it was all communication through WhatsApp. Hardly any time I could do video call. Whatever medicine they travel, he used to show me, okay, you take this medicine. I was myself confused. What? I'm thinking of HSV, is not responding. I'm thinking of they are cycling on shift, it was not responding. Thought of morsum contagion, I said, no treatment, when you come, we'll remove it. Secondary sepsis is not responding. Chancroid not responding. And then I thought of asking him how many partners we had in one night. He said 12 partners in the Netherlands. His ship was docked there. I said, any history of anybody getting mpox? He said, 3 of my 5 known partners are positive for mpox. 6 mpox. So, perianal and general lesions in mpox. So, these are some of the double manifestations, and we have plenty, but to categorize them, put into different categories, we keep on taking pictures, and it's for us, now they are less and less, but still we see cases because of HPV, because of gonorrhea, chlamydia, because of donor analysis, because of syphilis, and we see other double conditions also. Thank you.
Thank you, sir, for some light on dermal manifestations. Now we'll move on to the next talk because we'll take all the questions in the discussion time. So thank you, sir. And our next talk is on advanced HIV therapy with Bictegravir, the clinical perspectives and future directions. This talk will be given by Dr. DJ Bora from Gujarat.
ASICON welcomes Dr. Major DJ Bora. Dr. Bora is an HIV and infectious diseases consultant at Gujarat. Dr. Bora currently works with the government of Assam under the JICA-supported Assam Health System Strengthening Project, contributing to public health infrastructure. His background includes roles as Regional Manager with GSI, State Transformation Manager with Ramal Swasthya, and Regional Coordinator in NACO, demonstrating a wide range of healthcare leadership. Dr. Bora served as a Regimental Medical Officer in the Indian Army, indicating a commitment to service and experience in challenging environments. He holds an MBBS from Guwahati Medical College, an MPH, a PG Diploma in HIV Medicine, a PG Diploma in Medical Legal Systems, and a PhD in HIV, showcasing his dedication to education and specialization. We look forward in hearing him talk on advancing HIV therapy with Bictegravir clinical perspectives and future directions.
Yes, thank you. Good evening, everyone. Yes, it is the last session, but not the least. I am going to talk about the advancing HIV therapy with Bictegravir clinical perspectives and future directions. HIV disease burden 2020, since morning we have listened already that India still has a significant HIV burden, estimated 2.5 million lakhs of the HIV, and the new infections. It's a good news that it has been declined by 44%, but if we see the mother to child transmission rate is nearly 12% still. And of course, again, it's a robust result that 79% reduction in the number of age-related deaths in the last decade. NSP targets all of you know, but if we see the status at the end of 2023 in comparison to 2025 target, then we can see that out of the target of 80%, we have achieved the people know their HIV status is 79%. Out of that, 86% we initiated on ART. Out of that, 93 to 94% are married subjects. That means we have still miles to go. Need gap for the new drug in HIV. Integration inhibitor in state, it is a preferred regimen for PHIVs across the various management guidelines. Dolutegravir, only second generation in state, rolled out by NACO as the first and preferred regimen. Again, dolutegravir-based regimen showed good efficacy and tolerability. However, it is associated with weight gain, metabolic syndrome, as well as diabetes. So there is a strong need for another state, Bictegravir for the PHIV living in India. Bictegravir is a second generation HT approved by various drug regulators across the globe, US FDA, EMA, etc., including DCCI India. And the Bicta regimen, it is known for efficacy in many robust clinical trials. They did 5 years data, more than 240 weeks. And it has excellent efficacy in real world published studies from both global as well as in India. And it features in various international guidelines, DHS, EACS, as the preferred first-line treatment. Regulatory approvable status, globally, it was approved Bictegravir, emtricitabine and tenofovir, alafenamide. It was approved by US FDA in 2018, also by EMA in 2018. And by DCCA, it was approved in 2019 for the treatment of HIV-1 infection in adults who have no ART history prior, or to replace the current ART who are relatively suppressed, and there is no known substitutions associated with resistance to Bicta, emtricitabine and tenofovir, alafenamide. Guideline recommendations, European AIDS Clinical Society in 2024 recommended Bicta regimen as initial combination regimen for ART-naive adult PHIVs. Then the guidelines for the use of antiretroviral agents in adult and adolescent with HIV, United States Department of Health and Human Services, HHS, 2024 recommended initial regimens for people living with HIV. Then IAS 2024 recommended as an initial regimen for people with HIV, also as a switch therapy for biologically suppressed individuals. Some clinical studies that I was mentioning in my first slide, there is a 5-year study. So you can see here that 98.6% maintain HIV-1 RNA less than 50 copies per ml, both for Bicta-based regimen as well as the dolutegravir-based regimen. But we can see that also there is positive change in CD4 count from baseline. Conclusion is through 5-year follow-up, Victor regimen maintained high rate of biological suppression with no treatment emergent resistance and rare drug discontinuation due to adverse events. These studies highlight the long-term safety and efficacy of Victor, MT-7 and the tenofovir for initial treatment of HIV-1 as a first-line regimen. A switch from dolutegravir-based regimen to Victor-based regimen with adults with biological suppression. Here the inclusion, it was again a randomized control trial, phase 3, multi-center, double-blinded study. Inclusion criteria was more than or equal to 18 years of age, HIV RNA copies for less than 50 copies per ml for last 3 months, then no history of treatment failure, taking dolutegravir-based regimen, then no documented or suspected resistance to dolutegravir, then lemivudine, FTC, and TEF. Hepatitis C was allowed, but hepatitis B virus infection was not allowed because it may cause acute exacerbation of hepatitis B. There will be fear of infection if the person suffers from hepatitis B. That's why it was not allowed. If we see the result, that at 48 weeks, proportion with HIV RNA with more than 50 copies per ml was not statistically defined. It was found to be similar in both the groups. But if we see in terms of the adverse events, you can see that insomnia, nausea, and fatigue, it was much lower, even it is 0% in Victor regimen in comparison to dolutegravir-based regimen. So the features combination of the Bictegravir regimen might provide a safe and efficacious option for ongoing treatment of HIV-1 infection. Then twice daily Bictegravir regimen with rifampicin infected people with HIV and TB, that is CAPRISA inside trial. Here we found that results 95% of participants in both the arms HIV loads less than 50 copies at 24 weeks. Median CD4, but you can see median CD4 with respect to Victor was 96. If we compare with dolutegravir, it is 69. When you see the adverse events, serious adverse events was seen 11% with Victor-based regimen, 7% with dolutegravir-based regimen. Grade 3 events, it is almost similar, 38 with Victor and 36% with DTG-based regimen. But if we see grade 4 events, it is only 8% with Victor-based regimen and 14% with dolutegravir. Primary endpoint, finding support of Victor-based regimen in people with HIV and TB may open a pathway for inclusion in WHO guideline and access in TB endemic settings. While suppression rates were high and similar in participants receiving Victor-based regimen versus dolutegravir-based regimen. Then Bictegravir-based regimen in biologically suppressed pregnant women with HIV. Design again, it was open level multi-center single arm study. It included 30 biologically suppressed pregnant women. Methods: participants were enrolled from second to third trimester through approximately 16 weeks postpartum. The study evaluated the proportion of participants with HIV-1 RNA levels below 50 copies per ml at day 1. Results: plasma concentration of Victor-based regimen was similar between the second to third trimester and between 60 to 12 weeks postpartum. Then Victor drug concentration during pregnancy were more than 6.54 greater. Then the protein adjusted 95% effective concentration. Conclusion: biological suppression was maintained in all adult participants as pregnant women throughout the study with no biological failure or treatment emergent resistance to HIV-1, no discontinuation because of adverse events, and no perinatal transmission. This is again Indian study. The reduction in the weight gain due to dolutegravir following switch to Bictegravir. At the end of the study, after the patients were treated on dolutegravir, mean duration is 20.7 months. The baseline weight was 70 kg. It was increased significantly to 81.23 kg. After switching over to Victor-based regimen for a mean period of 11.72 months, this weight reduced to 74.36 kg. Safety: yes, there is a black box warning, as I already mentioned, that is the post-treatment acute exacerbation of hepatitis B. That's why it is not included in the study. Most common adverse events like diarrhea, nausea, headache, fatigue, abdomen, dream, dizziness, insomnia, abdominal distension. Important pointers: Bictegravir-based regimen, good efficacy and safety in managing HIV infection, first-line treatment for ART-NACO, adult HIV, and switch therapy for biologically suppressed, long-term plasma half-life, biological efficacy is non-inferior to dolutegravir-based regimen, single one-sided tablet, simplifies treatment, improves adherence, reduces pill burden, effective in patients high viral loads and the coexisting health conditions, effective in drug resistance, mutations, Bictegravir regimen as a viable treatment option for a broad range of people. And in conclusion, India continues to have the second largest HIV epidemic in the world. There is definitely need for newer regimens which can be used as a first line or switch regimen in HIV patients. Based on DHSS, IS, and UN guidelines on HIV published data, Bictegravir-based regimen can be effective first line or switch regimen in HIV adult patients who are biologically suppressed. Advantages of Bictegravir-based regimen: once daily dosing, non-infective of dolutegravir in comparative trials. Published studies show high rates of biological suppression as well as good tolerability and safety to Bictegravir regimen. Thank you.
Thank you, sir. Now we can take questions or discussions or to any speaker. Yes, sir, please.
Okay, DDG and BIC. Okay, it happened. Same thing happened when we were working with the quinolones, ciprofloxacin, enoxacin, pifloxacin, spotfloxacin, and trovafloxacin. All of them came on equal efficacy, but they had side effects. Trovafloxacin because of hepatic toxicity, spotfloxacin because of photosensitivity reactions. Now, what BIC is claiming is that you have lesser adverse drug reaction, such as metabolic weight gain. I think tomorrow there is a presentation on hepatitis or jaundice as a result of DDG, etc. Now, is there any cost advantage? It's same. It's one daily dosing. So how would you want people to change? For what reason? Have you had so many million doses as that of DDG to see the side effects of the, because it's the same class. You know, how many doses have been administered in the world with BIC?
Yes, sir. Yes, I will try to answer. So first and foremost, it's a new molecule, and so there is from, especially from Indian evidence, there are very less data. So for me also, I have started only for ART-NACO patients. Although I have said that we can use for biologically suppressed, we can switch from the dolutegravir-based regimen to Bictegravir regimen. But for my personal patients, since I am comfortable and my patients are also used to it, they are full compliance with the dolutegravir-based regimen. Although my sir, for your information, my all patients are biologically suppressed. All of my biologists need. But then also I can definitely switch, but I am not switching because I think their compliance is good. Okay, I can explore it as a future therapeutic option if needed. So as an Indian evidence, but now I am going to try for my ART-NACO patients with Bictegravir. So coming to cost, sir, it will be sir, I am not the right person to talk about the cost and all, but I think, sir, if we compare the dolutegravir-based regimen, especially metabolic syndrome, diabetes also, what I have observed, Bictegravir causes less metabolic syndrome. Especially, sir, I have seen my personal patients who were treated in some public sector, they with dolutegravir-based regimen. Even, sir, some people develop diabetic ketoacidosis and all those because they used to do only the ART screening and give the ART only, but they were not bothered to screen thoroughly, especially by NCDs. So sir, that is one gray area.
So I have several comments about this. First of all, I do have patients on Bictegravir-based regimen who have put on significant amount of weight. So I think that the INSTI-based weight gain is a much more complex phenomenon than we think. And especially when you look at those people who are on INSTI and TAF-based regimen, and when we move them back from TAF to tenofovir, the weight gain certainly declined. So I think that First of all, weight gain in a naive patient who's given an antiretroviral is multifactorial. And yes, unlike most people, we actually screen our patients for NCDs, and we are very, very particular about it. So, and also the rationale for insisting on TAF versus tenofovir in India is still up in the air, because in our data analysis, we did not find the degree of quote-unquote renal disease, dysfunction, or bone disease with TAF to be substantially different from tenofovir. Okay, so I think that we need a lot more data before we can go around making these claims that Bictegravir is certainly more benign than plain old DMP. And in a national program, cost is a big deal.
The problem, the patient has a tuberculosis. Can we use this drug, sir?
Yes, twice daily regimen, sir. In case of the Dontagamil, we give separately. Yes, twice daily regimen in case of tuberculosis. Sir, can I add something? Just extra out of this. Yes. Just out of this topic. So I feel fortunate enough to be in this field because, sir, I have treated, staying at Guwahati, Assam, I have treated a lot of cases of satelaromycosis and histoplasmosis, all those. Sir, there was one case for, I will not name the patient name and from where he came. Of course, he came from Upper Assam. So when he came, he was treated in government hospital. Sir. Then he somehow, means from the reality center, they referred to me. So I saw when the patient, young boy, 30 years old, he came to me. Then I saw he was already diagnosed with extracontinental tuberculosis. Then WHO came to stage 4 disease, and doctor already started on ATT. Then, sir, further evaluation, I found that the patient was suffered from histoplasmosis. Then further, sir, patient was found, means I have started the treatment, patient went back. Sir, I admitted him for 5 to 7 days, patient went back home. Then after that, again the patient called me, sir, I'm having all this, okay, I'm having hemoptysis in between, and cough and all, okay, respiratory distress and all. Again I called him. Again in my mind, sir, of course I had my friends at Govt Awareness Center, he's the MD pathology from me, so I called him. Sir, he was my classmate, I called him, partner, I'm sending again one patient, the same patient, but you look for telomycosis also. Then he told me, he called me next day, okay, sir, Joy. I said Joy Bharat. That means he is again telomycosis positive. Then in the meantime, the patient wanted to be referred. He asked me, can you go outside? I told him there is only one person near to Guwahati, who is my student mentor, Dr. Professor Goa sir, and I did my PhD HIM under sir's support and guidance. So I took his appointment. I talked to Goa sir. He said, okay, send the patient. And sir, I'm very much thankful to you, sir. Sir treated the patient, admitted there in School of Tropical Medicine. And sir, he is absolutely fine. Thanks to you, sir. That's all, sir. Thank you. So, sir, it is a wonderful field. You can see that here. And it's one more case, sir. Sir, young boy, just one second, sir. Young boy means college professor. Sir, he was having chronic diarrhea, and he visited a lot of medicine specialists, even a gastroenterologist. Then somehow he was referred to me. I did the stool culture, found him cryptospore disease, started with nitazoxamide. After 15 days, he told me, sir, I go once only to toilet. I'm absolutely happy now. Thank you.
Thank you, sir. Thank you very much for your discussion. Any questions for any other speakers in this session are welcome. Otherwise, we are going to close the session.
Thank you. I would request our chairpersons to kindly hand over a token of appreciation to our speakers.